We've seen in the mini orals yesterday the 10-year overall survival data of the KEYNOTE-006 and the CHECKMATE 067 data. I think we were already impressed by this data, but it's good to see the really long term and see that only 1% of patients after 5 years will die per year of melanoma. So the majority of these patients are cured. I think that is really important. I'm really glad that we had a symposia discussing how we can support these patients, their long-term toxicities, which I think is mainly dry mouth, fatigue, also the endocrine side effects, but also how we can support them in their lives, picking up their lives in their resilience. So we, I think, had a really nice symposium about that. I think seeing these data, we need to shift our focus. Of course, the chance of getting a recurrence is never zero, but the main focus for these patients should be different. So I think we should discuss on how we should continue the follow-up for these patients. Should we keep on scanning? For example, in the Netherlands, we decided to stop after 5 years for the patients with a good response, but I know that it's different in different countries. So I think the focus needs to shift in these patients. Regarding quality of life, was a poster by Jessica Hassel in the poster session showing that most patients, most long-term survivors have a really good quality of life, but mainly those patients with long-term side effects do not. So I think we really need to look into them and how we can support them. What's also, I think, really interesting when you look into the data, long-term data of the CHECKMATE 067 was when James Larkin showed the difference of the patients that were treated with for immune-related adverse events. In the CHECKMATE 067, patients were randomized between Ipi-Nivo, Nivo, and Ipi in the metastatic setting, and we know that Ipi-Nivo, although not formally designed to compare, was superior to Nivolumab for the whole group. But when you look into the patients with severe immune-related adverse events, you saw that it was the other way around. So the patients with Ipi-Nivo did worse, and this might be due to the way we manage the side effects of these patients. We recently published in JCO different cohorts of different CHECKMATE studies with patients treated with Ipi-Nivo, showing that the steroid peak dose really affects their PFS and OS. So I think that's also something that we need to look into more, trying to have as many long-term survivors as we can when treating these side effects better than we do now.